Hello, everybody, and welcome to this Friday's Independent Sage briefing. We're on the cusp of some quite significant changes in the way that we're living our lives, as on Monday, the government is set to allow further restrictions to be lifted in the UK. But this isn't without risk, of course. The prevalence of the so-called Indian variant has more than doubled in the country over the past week, prompting discussions about keeping restrictions in place in certain regions of the UK. The spread of new variants reminds us of the stark reality that coronavirus will continue to mutate wherever it is freely circulating. But it does also remind us that we're all in this together, that this is a global problem, and that we as a country will not be safe until the entire world is safe. This is just one of the reasons that our government should commit to helping developing countries with access to vaccines. Next week, Professor Ravi Gupta from the Gupta Lab in Cambridge, who's been investigating the new variants of concern, will join us as a special guest, and we'll focus then on all things variant, but I expect this will come up in the discussion today as well. We've got a lot to discuss as ever, and we'll be taking your questions too. But first, we have the latest numbers from Dr. Kit Yates. Kit, over to you.
Thanks, Alice. So hopefully you can all see that. Not to over dramatize, but I think at the moment we are at a tipping point ahead of this proposed unlocking on Monday the 17th. And so what I want to do today in this presentation is to take you through where we are and whether we're meeting the 4 tests that the government set out. So we'll have a look at cases, short look at hospitalizations, we'll look at vaccinations, we'll look at schools, and then we'll finish by looking at variants. So to remind you before we start, the 4 tests that are outlined in the roadmap, before each new step of unlocking proceeds, we have to meet these 4 tests. The first one is that vaccine deployment is going well. The second one is that vaccines are actually working and slowing down, reducing hospitalizations and deaths. The third one is that infection rates aren't going to risk a surge in hospitalizations, which would put pressure on the NHS. And the fourth is a sort of vague one about the assessment of the risk not being fundamentally changed by new variants of concern. So we'll look into that in some detail, because that's probably the one that is potentially failing. So in terms of cases have been coming down across the UK since January, since we've been in the lockdown. So green is new confirmed cases, black is the 7-day rolling average. If I zoom in on the last few weeks, you can see that cases are coming down, although as of about last week, the absolute numbers of cases have started a small uptick. There have been week on week rises. If we look at each nation, this is cases per 100,000 now to make it comparable between different nations. And this is by specimen date, so the date that someone had a test. You can see that cases are pretty much flat across all 4 nations. Maybe slight rises in Scotland. Of course, testing we know can be influenced, can influence the absolute numbers. So we often like to look at the positivity rates, and doing that, you can see that positivity is either flat or falling across all nations in the UK at the moment, down at this right-hand side, and is really quite low now, below 2% in all the nations, which is really good news. So cases are low. This is from the office, this is prevalence, so not the number of new cases, but the number of people currently infected. This is from the Office for National Statistics weekly survey, where they get an unbiased selection of the population. It's not influenced by people going to get a test. They randomly select people. And again, you can see that prevalence is still coming down across all 4 nations of the United Kingdom. In terms of drilling down a little bit more into England, so these are the different regions of England, 9 different regions. You can see again that this is for cases per 100,000 in those regions are all fairly low and flat. Yorkshire and Humber has been lagging behind the rest of the regions a little bit, but is getting down there. There may be potentially small rises in the southwest, but from extremely low levels. And again, looking at the prevalence data, looking at the positivity data, you can see that most regions are still falling. There have been some small upticks recently. So we're sort of on the cusp. We're bottoming out, if you like, as Jonathan Van Tam suggested we would do. We're not going to get much lower than this, especially once restrictions are released on Monday, if that's what ends up happening. Again, looking at the positivity rates by these English regions, just so you can see in a little bit more detail, orange is the current week, grey is the previous week. So you can see there are a couple of regions where we've seen rises: the Northwest, the East Midlands, the Northeast. London stayed pretty much the same, as has the Southeast and the Southwest, whereas these regions have dropped a little bit. Everywhere in terms of positivity, apart from the East Midlands now, is below the September the 1st levels, which is green, although that has to be put in the context of the fact we are testing more, so we would expect positivity levels to be lower anyway. But cases are low, and the situation is quite good. Again, this is from the Office for National Statistics survey, and it suggests the same sort of picture, that cases are either flat or falling, or prevalence rather is either flat or falling across all 9 of these different regions. So cases are very low, which is really good news. Looking at hospitalizations, again, just one slide on this. Again, you can see we had extreme peaks back in mid-January, but ever since mid-January, hospitalizations have been falling and have been tracking infections with a delay. And you can see that they're continuing to fall across all 4 nations and are now, again, at very low levels. So in terms of the tests related to hospitalizations and infections, we are passing those at the moment. I'm going to move on to talk about vaccination data. So firstly, we know that the vaccines are effective, and that they're effective at cutting transmission as well as preventing severe illness and death. But is the rollout still going well? Well, yes, it is. We saw a dip last week after 3 or 4 weeks of consecutive rises. We saw a dip partly because of the bank holiday weekend, but now cases are starting, so vaccination doses are starting to rise again. This is the number of first and second doses, so orange is second and blue is first. You can see that we're predominantly giving second doses to keep up with the rate of first doses that were given 12 weeks earlier, but slowly we'll start to move more and more towards giving more first doses and getting more people protected. In terms of the number of people who are protected, we've given first doses to roughly 2/3 of the adult population, and over 1/3 of the adult population have had a second dose as well. We should be careful to remember that this still leaves 1/3 of the adult population without any protection at all from vaccines, and also children have not been vaccinated. So there's still a significant proportion of the population, largely the younger population, who have not yet been vaccinated, but we're still doing well in terms of rolling this out. Looking at the different nations, in terms of first doses, or people who've had at least 1 dose, Wales is surging ahead at nearly 3/4 of the population, and the rest of the nations are lagging around at about 2/3, about 65-66%. But still, everyone's doing fairly well. And in terms of second doses, people have been given both doses, you can see that the other nations have now caught up with Wales, which had surged ahead, and roughly everyone's vaccinated fully, or given 2 doses to about 2/3 of the population. So looking at first and second dose coverage broken down by age, you can see that for the over 70s, in fact for everyone over 50, the first dose coverage is at least 90%, which is excellent. And obviously for the older generations, we have high second dose coverage as well. We're starting to see higher numbers of first doses in the 40 age bracket. And in fact, this week, 38-year-olds and 39-year-olds have been invited to book their appointments. So we're going to have to extend that horizontal axis to the left to include those. So that's really good news. We're vaccinating more and more people. One thing which is of slight concern is the disparities across different regions. So this is second dose coverage for over 80s who should have all had their second doses by now. You can see that London's lagging quite a long way behind. Most of the regions are up at sort of above 90%, whereas London's around 75%. And what's perhaps another concern is if you look at the number of second doses given as a percentage of first doses, you hope that would be 100%, which would mean that everyone who got a first dose would get a second dose. You can see that it isn't. It's below 100% for most regions, but London, again, is actually the worst. So not only are they giving fewer first doses, but they're not following up as many of the first doses with second doses. So this is something to keep an eye on as we go forward. And again, by that same metric, if we look at splitting up regions by deprivation, so red being the most deprived and green being the least deprived, again, this metric of what proportion of people who were given the first dose have now had a second dose, this is for over 40s this time, you can see that that's highest in the least deprived areas and it's lowest in the most deprived areas. So again, as we emphasize every week, we need to be careful about inequity and inequality in vaccine uptake, lest COVID becomes a disease of poverty, and that's something we'd like to avoid. So we need to make all the efforts we can to try and make sure that vaccine rollout is as equitable as possible. A quick few slides on the situation in schools. So this is the number of cases per 100,000 broken down for ages, 5-year age brackets for ages under 20. So you can see that actually most age ranges are flat since schools have gone back around mid-April. You can see slight rises in the 10 to 14 age category and small rises in 5 to 9s, but nursery age children, preschool children are pretty much flat. And you can see that 15 to 19-year-olds have fallen slightly actually since schools have gone back. This is important in the context of the fact that masks are going to be suggested to be removed by the government on Monday, the 17th. So it's important that we keep monitoring this situation. How much of this is due to changes in testing? Well, we know that lateral flow device tests are being primarily used in schools. And you can see testing numbers have stayed roughly constant, certainly in comparison to how quickly they ramped up when kids went back to schools in March. They've stayed roughly constant. So those rises or slight rises and falls are probably actually real rises and falls, although everything is fairly flat in schools there. This is from the Office for National Statistics survey. And again, it hints that most age brackets, so this is not just schools, this is, primary schools, secondary schools, and then sixth form colleges and university students here. You can see that actually prevalence is low and decreasing for school age children, and it's pretty much flat for college students and university age students, and falling in other age categories. So that's positive news. One thing to bear in mind is these are the numbers of COVID outbreaks in educational settings, and you can see that since schools went back after Easter, those have started to rise again, although they are lower than where they were in March when schools first went back, and much lower than where they were obviously in November and December when we had very high levels of incidence across the country. And again, this is from Public Health England, as was the previous slide. This is just breaking the number of cases per 100,000 down by year group. And you can see small upticks towards the end. So this is different weeks of the year. We just finished week 18 last week. And you can see that in each age group, there are small upticks in the number of people reporting a number of cases in each year group, and that's true across all the age ranges. It's been fairly flat, and then we've seen a little uptick in the last week. So schools, something to keep an eye on, but at the moment the situation seems fairly stable. We'll see what happens after Monday. The last thing I want to talk about is variants. So this is related to test 4. Has our assessment of the risk fundamentally changed due to variants of concern? So we've heard a lot in the news recently about the variant that was first sequenced in India, B1617, and its subtypes 1, 2, and 3. So this is a plot of from the data from the COVID Genomics Consortium. So to get a handle on these variants, we actually have to sequence the virus and figure out what the differences are, and that takes some time. So these data only go up to early May. And this data comes from the COVID Genomics Consortium UK, or COG. And you can see that, yellow here is the P1, which is the variant first sequenced in Brazil. Red is B1617.2, so the variant of concern that was announced last week by Public Health England, which was first sequenced in India, and B1351 was first sequenced in South Africa. And you can see actually that, so these are cumulative charts of the total number that we found in the country over all time. And you can see that they're still increasing. So we still have levels of Brazil and South Africa in the country, but they're not increasing anywhere near as rapidly as the Indian variant has it has been increasing over the last few weeks. So cumulative plots always make things look a little bit worse. So what about the numbers per week? Well, you can see again that we've got relatively flat constant levels of P1, of B1351, so Brazil and South Africa, and of one subtype of the Indian variant, so B1617.1. But actually the one we're concerned about, B1617.2, you can see almost exponential rise in the number of sequences that are being reported. It doubled the previous week, and it almost doubled again the last week, which data was available for. This data though is 2 weeks out of date now, so you may expect these numbers to be much higher now. Again, as a proportion of all the variants that were sequenced, so including the dominant British for the variant that was first sequenced in the UK, B117, the Kent variant, you can see that the other variants are not gaining much traction, but B1617 is increasing in proportion, increasing in numbers and in proportion of the number of variants sequenced. So it's growing even in the situation where cases themselves are flat or falling. It's increasing its share of the variants. So you could say, well, this data from COG includes all tests that were sequenced, including travelers and surge testing. So that might be a lot of the reason behind these large increases in number, because maybe people are coming into the UK from India and bringing this with them, or we're surge testing around areas of concern. Well, the Sanger Institute tries to remove cases related to travel and surge testing. And you can see that once you do that, this is just for the 3 Indian variants, the variants first sequenced in India. You can see that actually the numbers are actually overall lower because you've taken out some of the travel, but you can see the trend is the same, that B1617.2 is growing quite dramatically. And again, this data is 2 weeks out of date at the moment. Similarly, if you again look at the proportions that were sequenced, then you can see that B1617 accounts for, even discounting travel related cases or surge testing, B1617 still accounts for over 10% of all the cases that were sequenced. And that is obviously concerning, because it's getting a bigger and bigger share, even in comparison to our highly transmissible Kent variant. The final sort of nail in the coffin for whether this is just travel related is, well, India was placed on the red list around the 23rd, 24th of April, which is indicated with this red line here. This is data from Public Health England showing the number of B1617.2 cases by specimen date. And they're color coded by whether they're related to travel or not. So blue ones are travel or contacts of travelers, that's the light blue, but yellow is non-travel associated, and gray is still under investigation. And you can see, even since we've had India on the red list, we've got still increasing numbers and increasing proportions of those not related to travel. So it hints at community transmission of this variant, which is what we're seeing. It agrees with what we're seeing in places like Bolton and Blackburn. Again, just looking regionally, so this is all regions where B1617 is currently above 5% of the variants that are being sequenced. And again, this only goes up to the 1st of May, but you can see that in London, it accounts for 25%, a quarter of all the variants that were sequenced. And in the Northwest, it's over 20%. So that even at a regional level, you can see there's disparities. Some regions actually don't seem to have very much of it at all, like Yorkshire and the Humber in the Northeast, but actually London and the Northwest and the East of England have high percentages of cases are B1617 at the moment. And this is the sort of the final proof, if you need it, that B1617 is growing. So these are the proportion of cases that are detected with and without S gene dropout. So what does that mean? Well, when the Kent variant was becoming dominant in the UK, we found out that when you did PCR tests with it, they're looking for 3 particular regions of the genome, and actually one of those regions wasn't present in the Kent variant. So you could actually quite readily tell how fast the Kent variant was growing just by PCR testing without having to wait for sequencing. So this data is more up to date than the sequencing data, and it's also, there's larger numbers of it. So what you can see is here, the purple is cases with S gene dropouts. That corresponds to the Kent variant, and the green is without it, so that corresponds to other variants. And you can see that the Kent variant was dominant for a long time over January, but actually now it's stopped being so dominant, and other variants, presumably B1617.2, are starting to take over, and that's more evident in this zoomed in plot here over the last month or so. And again, if you look regionally, this is again a more up-to-date picture. It suggests that in London at least, and in the northwest, B117, the UK variant, is no longer the dominant variant in these regions. It's actually other variants which are dominant, and you can see the same picture repeated in different regions, apart from perhaps in Yorkshire, in the Humber, in the West Midlands, and the Northeast, where it's other variants have gained less of a foothold. But still, that agrees very much with the sequencing data which we saw. So with all that in mind, we have to ask ourselves the question, are these variants of concern changing our assessment of the risk? Well, there's modelling that's been done by SAGE, which suggests that if this variant is more transmissible, which it seems to be because it's gaining a foothold, then we could see big surges in the number of hospitalizations, which could match what we saw in the first wave, even without any immune escape of this variant. And if there were to be immune escape, then the Warwick modelling that feeds into SAGE suggests that we could see numbers of cases which outstrip the number of cases we saw in the second wave. So in my opinion, this is something that we should be concerned about. So in terms of just summarising, cases have started to rise slowly, although positivity is still flat. So it suggests that testing might be behind that. And the picture is slightly mixed regionally, but cases are low. So that's really good news. Vaccination rollout is still going well. Of course, we have to bear in mind that there are always disparities, and we should try to do everything we can to eradicate those. There have been small rises in school-age children, but that in terms of the number of cases, but the prevalence rates from the ONS suggest that that prevalence is flat or falling in school-age children, so we'll have to keep an eye on that as masks are removed on Monday. What we have seen is that B1617.2 is increasing rapidly. It's not linked to travel, it is community spread, and it suggests that it is highly transmissible. I think that's the view of most scientists, although it hasn't been entirely confirmed yet. It's spreading in areas where other variants are falling, which again suggests higher transmissibility. And the good news at the moment is that there's no firm evidence that vaccines don't work against it yet. But nevertheless, with increased transmissibility, maybe if it were 30 to 40% more transmissible, we could still have an extremely unpleasant exit wave if this wasn't contained. So I'll finish there, and I will pass back to Alice. Thanks.
Thank you very much indeed, Kit, for that roundup of the latest facts and figures. We're now going straight to questions from press and the public. And first up, we have Nigel Nelson from the Sunday People. Nigel, what's your question?
Hi, Alice. Yes, on the Indian variant, are we heading towards another national lockdown? And if we're not, should we be, given that it was the failure to do so that let the Kent variant take off at the end of last year?
Thank you very much. I think that's the question on everybody's lips, isn't it? Who would like to start with that? Do we think we're heading towards another surge and another inevitable lockdown? Gabriel, Professor Gabriel Scally.
It is the key question, isn't it? And I think Kit's data presentation made it perfectly clear the difficulty we have and the danger we're in. Is it heading towards another lockdown? Not at the moment. But if we don't get this variant under control, and if we don't get the virus under control, and it looks very much as if this variant is going to be the dominant variant, if we don't get the virus under control, well, there is the possibility, because of its increased infectiveness, that it will spread and it will affect a lot of people. It may not cause as much illness and death as we've seen, but illness it can cause. And we don't know yet whether this particular variant also, as well as being more transmissible, we don't know if it has more serious effects on people who get infected. So there are very good reasons why we should get it under control and keep it under control. And it's not, for me, it's an interesting question. It's not a question of, are you going to put your money on it being a big wave, or are you going to put your money on it not being a big wave? What we've got to do is prevent any risk of it being a big wave. And the best way to do that is bring it under control. And the best place to do that is locally. So we do need really a program of action at the local level. We need to empower local directors of public health. We need to give them the resources and the tools they need to do the job. We need to think about vaccination in a different way so that it will control these surging outbreaks or flare-ups at a local level. We do need to take test and trace seriously. We do need to test close contacts. We do need to really support people in communities, in local communities. It's time for a real community effort, locally led, locally responsive, but nationally supported. The resources need to be given. And we should look upon it as what we're going to have to do for the next period of time, because I think, unfortunately, over the next year or two anyway, we may well see flare-ups and outbreaks happening, and they will happen in some of the most deprived and unprepared places in the country. So now is the time to get it right, to put our eggs in that local basket and to make sure we get vaccination there and get a good response to cases there and suppress the virus at that local level right now.
Thank you, Gabriel. Professor Anthony Costello.
Yeah, I'd just like to endorse actually everything that Gabriel's said. You know, throughout this crisis, it seems that the central government view is that you go for vaccination, which is all good, or you have a lockdown, a national lockdown. And clearly that's very damaging to the economy, as we all know. And what you ideally want is to lock down the people and the populations that are most affected. And that's why you want to test. That's why you want to trace contacts accurately. We pick up on average between 2 and 4 contacts per case. It's been 2 overall. Taiwan and other countries were picking up more than 10. So we're missing lots of contacts. When we find them, we know from previous surveys they're not necessarily complying with isolation. And most of all, the most vulnerable communities are not receiving financial support, and therefore there's no incentive for them to get a test. You've heard all this before, repeatedly. But if we're really going to keep these outbreaks, and after this variant, there'll be another one and another one, we need to have strong local responses. We have to strengthen local authority directors of public health. And I was alarmed actually to read yesterday that in Blackburn and Darwin, where they're trying to get things under control, the excellent local public health team, who've got great local data, decided to do surge vaccination. And that's been jumped upon, apparently, by the centre. So I think we need to be shifting power from the centre to the localities so that we can get control over these outbreaks as they occur. Whether we end up in a national lockdown because that's not going to be done quickly enough is another issue.
Thank you very much, Anthony. Professor Christina Pargle.
Yeah, so just to add to that, I think the current situation with this variant of concern just highlights the importance of our international policy, in that that our red list policy just isn't good enough. We spent January and February worried about Brazil and South Africa, didn't worry about other countries. It turned out that the next dangerous variant was from India. By the time India was surging and it became known, it still took another month to put India on the red list. And we don't know where the next dangerous variant is. Absolutely no idea. And so to have this kind of idea that we can always just react by putting selected countries on a red list is just not good enough. And so maybe we will get control of this variant, but there will be another one, and so I think our international policy has to change. I also think we have to promote international vaccination, because that's ultimately the safest way to get out of this. So we can't just always just think about our own problem and react to it. We have to think a bit more proactively and try and prevent it from happening in the first place.
Thank you very much, Christina. Does anybody else want to comment at this point, or move on to the next question? Thank you for your question, Nigel. And the next question is coming from Alexandra Thompson from Yahoo. Alexandra.
Good afternoon, everybody. I wanted to go into a bit more detail about what Dr. Yates said at the end of his presentation. He said there's no firm evidence at this point that the B.1.617 variant can evade the vaccines. Is there any evidence you're aware of that may be laboratory-based at this stage? How concerned are you, just generally speaking, and maybe some perspective that perhaps people are panicking unnecessarily based on what we know at this point? Thank you.
Thank you very much, Alexandra, and straight back to you, Professor Christina Fargel.
So obviously I'm not a virologist, but next week we will be having Professor Gupta on, who's been investigating it. And I know he's released a couple of preprints looking at B.1.617 and showing that there is some suggestion that it reduces the level of antibodies in response, but that's mainly a different subtype. It's 617.1, and that emerged earlier, so there's just more data on it. So they are currently looking at the second subtype, but we don't actually have that much evidence about it. So that is one of the problems right now, is that we're in a bit of a kind of an information vacuum on that, which I hope we'll get new data on in the next couple of weeks.
Thank you very much, Christina and Gabriel.
The Public Health England put out a document quite late yesterday afternoon or early evening that dealt with the variants. And when they talked about this particular variant identified in India, they said with regard to vaccines that their risk rating was low. But they went on to say that there was no live virus neutralization study carried out using the vaccines in use in the UK and so on. And they said national vaccine effectiveness monitoring for this variant has commenced, but there is currently high uncertainty and iteration is required. So yes, the jury is out on that, and work is taking place, and it's good that it is being looked at, because that is the real, one of the key risks behind it. And similarly, they also said there is no data on vaccine effectiveness against severe disease. So in the absence of that information, the only thing we can sensibly do is take a precautionary approach and regard it as potentially dangerous and act accordingly.
Thank you, Gabriel. And in the context of that report published yesterday, is that an unusual thing to do, to label an element of risk as low risk when you don't actually know what the risk is yet?
Well, I was surprised to see it, Alice, as you might have guessed from the way I said it was labeled low, and then said the description against it. Mm-hmm. And it may well be that they do not want to alarm people, but I would have had a very large question mark there, I think, rather than giving it a low rating.
Thank you very much. So we can't reassure you, I'm afraid, Alexandra, but there are a couple of other people that want to comment. Professor Carl Friston.
Yeah, just in relation to the degree of panic, listening to people talk, I can imagine a lot of people are worried that we're facing a very similar situation that we were in last November, with a stepwise change in the transmissibility of the virus, and the whole nation's going to be subject to a subsequent wave. I think it's worth pointing out from a national perspective, from a very coarse-grained perspective, say if you were commenting upon UK from Canada or America, that the situation is very different now, in the sense that the number of susceptible people in the population is substantially lower in virtue of vaccination. And what that means is that you're going to slow down the spread of any variant, even if it's more transmissible, considerably and substantially in relation to what happened to us last Christmas. So whatever is going to happen is going to happen much more slowly, even to the extent that you could argue things like some national lockdowns are highly unlikely. Having said that, the other big thing which speaks to Gabriel and Anthony's response to the previous question, the other big thing that we know is there's enormous interregional variation, both in the vaccine uptake and therefore implicitly the proportion of susceptible people, and therefore implicitly the rate at which it could resurge. So the big question now is identifying local pockets of people who haven't built up a community resistance in order to prevent them experiencing. So they should be panicking. and particularly the public health directors should be panicking if they don't have access to the right levers in order to suppress local outbreaks.
Thank you, Carl. And Carl is not one to panic. Professor Stephen Reichert.
At this stage, there are certain things we do know and certain things we don't know. What we do know, as Kit showed very clearly, is that the amount of this new variant is rising and seems to be rising ever more rapidly. So it was doubling for a number of weeks. Last week, it went up from 520 to over 1,300, so nearly tripling. We know that. The second thing is it seems it's more transmissible. We don't know how much more transmissible, but we know it's more transmissible. What we're not quite sure about yet is about degree of vaccine escape. There may be some, and about levels of seriousness. There doesn't seem to be much data that it's much more serious. Nonetheless, if a lot of people get infected, then a lot of people are going to get ill and are going to get hospitalized. So we have to be concerned. Exactly how concerned we are, we're unsure about. So one issue is, what do you do in the context of that uncertainty? Now, a lot of the controversy is around the issue of, do we reopen indoor spaces next week, which is where we know all the danger is. Outside is relatively safe as long as you don't do silly things like, get right up close and breathe in people's faces, but it's indoor where the danger is. So there's a real risk in that area. And we have to think about balancing the different risks. What is the risk of not opening versus what is the risk of opening? Everybody wants to meet up in houses. Everybody wants to go to restaurants. Lots of people want to go to the bar. Is it worth putting that off for 2 weeks so we don't potentially get into a situation like other countries? I mean, that's a difficult decision. However, having said that, there are a number of things which are absolute no-brainers that we should be doing and we're not doing. And we need to put the focus on those things as well. So we've already pointed to the local test and trace systems, making sure that we very rapidly identify outbreaks, identify contacts, have enough contact tracers, all the things that Anthony has talked about very eloquently for weeks. And that's not happening. We should be giving more support to people who need to self-isolate. That becomes more important than ever, partly because if they're out and about, it's more serious, and partly if they have this new variant, it's even more serious. And again, we're still not doing that. What's more, with this variant, because there's indoor transmission, it makes it even more important, not only that you give money so people can afford to self-isolate, but that we also give accommodation to people so they can self-isolate outside the home. A no-brainer. It's not being done. And when it comes to our public spaces, number one, we should make sure that they are all properly ventilated and properly distanced and nothing opens until that's so. When we should be giving support grants to make sure that that's happening as well, so the spaces we go on into are safe. Again, those are all no-brainers, and they're not happening, and they're not only important for this particular variant, they're going to be important in the future. There's a lot that we can be doing that isn't controversial and which the government is not doing, quite apart from Christina's absolutely critical points. But the reason why this is coming about is because of the pandemic raging internationally, and that as good international citizens and for our own self-interest, our government, which is one of the few which is blocking the lifting of patents, one of the few in the world in danger of becoming an international pariah, must change its position on that as a matter of absolute urgency.
Thank you very much, Steve. And Alexandra, thank you for your question today. I've got a question now to read out from Sarah Woolley. She says, in India, there appears to be an increased death rate in younger people, even those who can afford care. Are we going to speed up vaccination of the younger age groups? Additionally, some of the older population received their second vaccinations back in January. Will they be at risk if infections rise and their immunity wanes? Who would like to start with Sarah's question? Professor Anthony Costello.
Whoops. Yes, I mean, I've heard the stories from India, and I believe that it's kind of anecdotal. I think there were some doctors from the south of India who were saying they were seeing many more cases of younger people. We just don't, it's very difficult to act on that and to know to what extent that would be true in a very different population like the UK, although it's something obviously we will need to study. In terms of the vaccination argument, my own view is that children down to beginning of secondary school age are as vulnerable to long-term COVID as older people. And in that sense, this is a completely personal view, we haven't discussed this on Indie Sage, would support the idea that vaccination should be offered down to that age. I think in primary school it's different, and there may be objections to doing that and priorities. But if you did include the further cohort of children down to age, say, 11 onwards, then you would increase your numbers of people across the population who are vaccinated. And that may actually be quite important, because as variants become more transmissible, you don't achieve herd immunity until much higher rates of immunization. I mean, at the beginning of this epidemic, people were saying, look, if we get to 70%, which we're nearly at the moment of the population, of the adult population, then we should be able to stop transmission. But now we're thinking it's going to be high 80%. So extending the age range of vaccination is something that needs to be considered. And I think probably the JCV, the Joint Committee on Vaccination and Immunization, will be talking about that at some stage.
Thank you very much, Anthony. Moving on now to a question from Michael McLennan. Michael, are you with us?
I am indeed. Hi.
Go ahead.
Yeah, hello there. We're launching COVID Aid this month, say national UK charity. We've recognised that people affected by COVID-19 will require support, not just now, but in the months and years to come. So my question is, what do you think are the most concerning long-term effects of COVID, both for individuals and for society as a whole? And then, as the founder of a new national COVID charity, I was wondering what you believe is needed to tackle these effects.
Thank you very much, Michael, and congratulations on launching your new charity. Who would like to start with this then? So look at a charity which is aiming to look at helping people with the long-term effects of COVID. Dr. Zubaida Haque, would you like to start with that one?
Yes, I think it's a fantastic idea, and congratulations on setting up this organisation. It is fantastic that you've set it up. I really sincerely hope that the government help you with grants and you get local grants, because this is it. We don't know at the moment still what the long-term, social, economic, mental and health consequences of COVID will be. With the evidence on long COVID, the evidence is coming in all the time. My colleague Anthony spoke about how long COVID has affected young children. And we know that, we know that 7 to 8% of children have long COVID at 5 weeks, actually 13 to 15%, I think, or 12 to 15% of teenagers have it around, 3 months later. But we don't know. We don't know what the long-term consequences are, and certainly in terms of social and economic consequences, there will be lots of decisions there. So hopefully you will get more grants from the government, and hopefully the government themselves will be looking at this issue post-COVID as well.
Thank you very much, Zubaida. And Professor Susan Mickey.
Thanks, and good to hear about the charity, Michael. And I'm wondering what the brief and the role of the charity is, whether it goes beyond helping individuals, because obviously in the future, a key thing is going to be learning the lessons of under-resourcing and underinvestment in key bits of our society, especially the National Health Service. We see the huge and accumulating backlog and people on waiting lists, but also the public health infrastructure, which has been really diminished over the last decade, and we're unfortunately reaping the results of that. The other big issue is the increasing inequalities that's happened as a result of pandemic. And so I think there's some of these broader structural issues that are going to be really important in terms of helping people in the short term and in the long term, and ensuring that come the next pandemic, because unfortunately It's not a question of whether, it's a question of when. That's what we all said in 2009 after the H1N1 pandemic. Putting the whole society into a more resilient position. And that requires individuals working with community networks and organisations and putting pressure on those with the power and influence to change some of these more fundamental issues.
Yeah, I think that's
Thank you.
something that we're hoping to help with as well. Thanks.
Great.
Brilliant. Thank you, Susan. Does anybody else have any advice or any comments here for Michael? I was wondering if you might have any opinions on this, Tallulah, Dr. Tallulah Oni. Would you like to come in here?
Yes, I would. I hope my my internet bears out. I'm just struggling a little bit today. I think the point I was going to raise is very much aligned with what Susan raised, which I appreciate. I think the really critical thing that we've learned, I really applaud your initiative. Really critical thing we've learned is that in the middle of an emergency is perhaps not the best time to start initiating engagement or to try to build trust. And so whilst we have had to do that in the middle of this emergency, it's really important that initiatives like yours are really looking to sustain this engagement and build that trust as part of community participation. Can you hear me okay?
Yep.
Okay, I'm not sure. Alice, are you?
Yes.
Alice, you're muted. Okay. Sorry. So I think that's really, really critical, that that sustained impact, the sustained engagement, and that building trust, and that to actually design our preparedness for the future. So one of the things I've said before is, if we're going to rethink the exercises that and simulation exercises we've done in the past, could we rethink it in a way that actually engages community representatives, members of the public, or organizations like yours as part of preparedness for future emergencies? So I think that's really that long tail of what emerges from this pandemic is going to be really critical. Thank you.
Thank you very much, Tallulah. Thank you for your question, Michael, and good luck with the charity. Thank you for coming along today. Moving on now to a question from Simon Williams. Simon, are you there?
I am, yeah. Hi, everyone. I mean, firstly, thanks so much for the vitally important work you've been doing throughout this pandemic. And actually, we've talked a little about this, actually. Professor Costello and Reichert earlier mentioned this, but I'm going to ask my question anyway. We did a little bit of research in Wales, commissioned by the Welsh Parliament, looking at people's experiences of being asked to self-isolate and the experience of self-isolating. And it obviously comes as no surprise to yourselves and the research that many of you have been doing that one of the major impacts was on mental health as well as financial impact. So, in light of the concerns, as was mentioned earlier, over rising rates and the potential even of a third wave and new variants of concern, is test, trace, isolate and support where it needs to be, and what more could or should be done by government to support those experiencing these types of challenges related to mental health or otherwise?
Thank you very much, Simon, and straight over to Susan Mickey for an answer here.
Yeah, a great question. And I think it's really worth looking at other countries and what other countries are doing. And many countries contact people every day to find out how they are, how they're getting on. And many countries, even relatively poorer countries, actually visit every day, knock on the door to find out how people are, is there anything they need? And some countries even offer psychological support if it's needed. So they monitor the clinical situation in terms of physical health, but they also monitor the mental well-being, in terms of, is there any psychological help that's needed? So I really think there's no excuse for a country like ours not learning the lessons from what other countries are doing really successfully. And we know that the mental health burden is escalating. And it's not being matched by the resources to address it. So one thing we should be doing is trying to present it prevent it escalating further, as well as trying, obviously, to get the resources to deal with the results of it. So isolating on your own, often at home, or even isolating if you're not on your own, can be incredibly stressful. And knowing that there's somebody there who you can talk to every day, who will be asking about you and could help with whatever's required, really important. So I would say that's one very obvious thing that we could be doing differently than we are at the moment.
Thank you, Susan. And Stephen, over to you.
I mean, absolutely, to echo Susan. And of course, we don't only have to look abroad. We can look in this country to examples like Newham. And we heard a couple of weeks ago from the mayor of Newham about their scheme, which includes that dimension of emotional support, which is really important. And I'm really glad that you've put the question of mental health on the agenda, because we don't talk about it enough, and it is absolutely critical. But I think it's really important, however, to stress where the problem lies. So, for instance, the president of the Royal College of Psychiatrists a while back talked about a coming tsunami of mental health problems, estimating that over 10 million people will have new mental health problems in this country. I mean, an absolute coming disaster. But he stresses that the problems aren't simply due to what we call lockdown. They are also down to many other things, such as the anxiety and the stress of getting illness, or the potential of getting illness, of children worrying about their parents, about financial worries, and so on. In other words, it's the pandemic itself which is the cause of much of the mental health problems. And a couple of weeks ago, there was a really important paper in The Lancet showing that when you look at health, and when you look at economy, and even when you look at civil liberties, they all go together. And the countries that are doing best are the ones that are reacting hard to get on top of the pandemic. And I think that's true of mental health as well, that to the extent you get on top of the pandemic and you can reopen and people aren't worried, you deal with the issues of mental health. So I think it's really critical to address that issue and to factor that in as another reason why it's so important to have fast and adequate responses when we see rising infections and when we see dangers as we are now. But that's not to underplay the issue of isolation. And when we're talking about rebuilding our society and rebuilding back better, I hope that one of the things that moves up the agenda is the issue of isolation. We're a society which is atomizing people more and more. We're a society which turns us into atomized consumers rather than communities. And that's something we need to change, because the issue of isolation is a public health issue. There's research to show that the consequences of isolation are more serious than heavy drinking, than heavy smoking, than the bad diet. And it's a social issue, and it's a question of the sort of society and making sure that people aren't isolated. And I hope that your work will put that on the agenda as one of the key dimensions when we talk about building back better.
Thank you very much, Stephen. And I'm so pleased that you've raised that incredibly important point that, loneliness was an epidemic before the pandemic. And, something that we need to look very carefully at afterwards. Simon, thank you so much for your question. Moving on now to a question from Robert Darlow. Robert, are you there with us? Hello, Robert.
Good afternoon.
Hello, we can hear you.
Great. I think I've developed another 50 questions, but never mind. The public inquiry into the COVID pandemic is scheduled for spring next year. The quality of its outcomes will depend greatly on the quality of its inputs, including data. So what important gaps in the data does IndySage believe should be filled before then? Thank you.
Thank you very much, Robert. Who would like to start with that? Professor Gabriel Scally.
Thanks very much, Robert. I've been involved in quite a few inquiries in my time, and they are really difficult to get right. And I think you're quite right. The preparation work is extraordinarily important and can be extremely valuable. It starts with who is going to conduct the inquiry, how it is going to be conducted, will it sit in public all the time? Key to it, I think, is the terms of reference. And I would very much like to see a public discussion about those terms of reference. And they should be developed not in secret, but there should be consultation about the terms of reference to make sure they're adequate, because this is something that has infected the whole of society. It's not a very discrete, small group of victims. We've all, in some sense or other, been victims of COVID-19, so we all should be involved in setting the scene for the inquiry. And part of it, you're quite right, will include high quality data, and it would be, I think, one of the incumbent on the inquiry as it is set up to identify how exactly they are going to get that data and to agree who should be providing it and how it can be assured to be accurate and how it can be guaranteed to be impartial. So we're a long way off all of that, but we do need to start to think. And I think it is important for those who may want to hear their views taken into account to consider how they should participate and how they would like to participate. And it's not too early, I think, to think what sort of groupings and what sort of coming together there should be about presenting evidence to the inquiry and engaging with the inquiry in the over the course of its operation. I think personally one of the key decisions will be how it will operate. Will it operate just as one very large inquiry, or will there be the work be segmented? I suspect it should be segmented. Will it operate over a prolonged time scale? I think that's almost inevitable, but should all those segments run in sequence or all at the same time? I think there is a good case for us doing some preliminary work in the inquiry about what actually is needed to keep us safe, because we've no guarantee that it'll be 100 years until another pandemic, nor 10 years, nor even 1 year. And there are things that are so manifestly deficient in terms of the UK's response that they deserve to be the work to be set and trained to address them as soon as possible. So I think all of those matters need to be taken into account, and it's great to hear that someone is trying to think through those issues, and we do need a lot of public discussion about precisely the sort of questions that you've raised. Thank you very much for asking the question. It was a great one.
Thank you very much, Gabriel. And I'll come to you next, Zubaida, and then to Lula. Zubaida.
Thank you for asking that question, Robert. And I don't know about you, but I am angry and frustrated by the government's response to a public inquiry about this pandemic. I am very upset by Boris Johnson kicking the ball into the wrong grass, because frankly, that's exactly what he has done. To say that this inquiry should be in a year's time, to be honest, who's going to care that much about the detail then? People will have been exhausted. We already are exhausted by this pandemic. We've been in 3 lockdowns. We've had a devastating number of deaths. And frankly, we could have learnt lessons a lot earlier had the Prime Minister carried out a public inquiry, a quick one last summer. Just think, we may have even been able to learn to avoid the second wave by learning the lessons from the first wave. Had he done one over the autumn, we could have avoided the deaths and the hospitalizations, the tens of thousands of deaths and hospitalizations from January. And on each occasion, we've seen the Prime Minister circumnavigating that call for a public inquiry, completely avoiding all responsibility. There have been so many mistakes in this pandemic. The Prime Minister has dithered and delayed with lockdowns, which have had devastating consequences. We have a test and trace system, which is not fit for purpose. There are a litany of issues which could still be fixed, We are not out of this pandemic. So I don't know about you, Robert, but I'm not really happy with the answer of we can wait for a public inquiry until next year. And I think we should still demand one now.
Thank you very much, Zubaida. I mean, I think the distressing thing about this is that it presumes that it kind of questions the purpose of the public inquiry. A public inquiry should be about modifying our approach now. It should be about helping us to do things better. And to put it off till next year means that we waste all that time, all that opportunity to be doing things better. Would anybody else like to comment on that? Tallulah, sorry, I was going to come back to you.
Mary, thanks. It's just to pick up on the point that Gabriel made about the terms of reference and the importance to have actually a participatory approach to developing those and an accountable and transparent approach to developing that, as well as Zubaida's point about learning lessons, because the KIT's presentation has shown that we're still very much needing to learn. I want to add to your question about what data we need to extend the definition of data, right? So part of it is the scientific and data that we need to inform those terms of reference and the scope. The other is the qualitative data that we need, which is the voices of the people who have been impacted by the pandemic. And there is nothing more powerful, apart from numbers, than actually hearing voices and experiences of people. And things like the People's Inquiry is going on at the moment. So that's been going on since February, hearing from the bereaved families, hearing from frontline workers, hearing from key workers on the deficiencies and the ways that they've been scarred and really impacted by this pandemic. And there are lessons there that could both inform what we do now and next, as well as the terms of reference of a statutory public inquiry. And so it's really important that we capture these ongoing initiatives by organizations that have taken it upon themselves to hear the experiences of people like the bereaved families, and actually hopefully emerge from that evidence that can inform the terms of reference and inform the approach to a formal inquiry.
Thank you so much, Tallulah. And Susan.
Thanks. To add to what others have said, I think in terms of the timing, what I'm not clear about is the idea that next spring the inquiry starts taking evidence. If that's the case, and we spend the time between now and next spring getting everything into place, all the proper consultations, engagement with all the right sections of society, an independent chair, it all set up and constructed, the terms of reference, all the procedures. So all that work has gone in so that come the beginning of next year or spring, the evidence begins getting taken and there's an endpoint. Where's the endpoint? When is it going to produce its results? Then I think that would be one thing. If this process isn't even going to start till next spring, I think that's completely unacceptable. The other thing is, I think for this to firstly produce useful results and secondly be trusted, is absolutely key that this be independent of government. Not only be seen to be independent, but be independent. And also that everything's transparent, everything's in the public domain, because otherwise we've seen too many of these kinds of investigations that have taken years that aren't trusted. I mean, look at what happened with Grenfell, and that doesn't produce timely results. So I think it's an incredibly important issue. And, I hope that all of those listening to this in their respective networks and bodies, as well as us, do everything we can to bring it forward and to have it prepared for and conducted using the kind of principles we've been outlining.
Thank you very much, Susan, and Robert, thank you very much for that question. We're going to squeeze one last question in, which I think might be a question for Anthony Costello. It comes from Ed Makara. Ed, are you with us?
Yep, I'm here. Can you hear me?
We can. Go ahead.
Right there. I'm one of those lucky people in this country who is a Manchester City supporter. And we're in the European Cup final, which will be taking place in Porto at the end of this month. I think about 20,000 people will be going from Britain, probably 30,000. Is there anything they should be particularly worried about? And as somebody who's double vaccinated myself, is there anything really much a double vaccinated person should be concerned about?
Thank you very much, Ed. Anthony, would you like to respond?
Well, leaving aside the issue of whether Manchester City and Chelsea should have been suspended from the competition for their Super League activities, but we better not get into that. I think it was very sensible to move it from Istanbul, but I think it should have been moved to Britain for obvious reasons, given the situation, why you need 20,000 supporters traveling. And at the moment, there's some issues about Portugal. I believe the reason that they agreed to this was because there are so many broadcasting UEFA people that would be flying in to support the broadcasting of this match. I still think it makes much more sense, and I still think it may even happen that we have to move it to a stadium in the UK. And then, of course, whether, you know, how the crowd management takes place will depend largely on the progression of the, you know, what's happening in the next 2 or 3 weeks. But I can't actually remember when is it? In about 3 weeks' time? Or a month?
It's 2 weeks tomorrow.
2 weeks tomorrow, yeah. But if you're double vaccinated and you're going to Portugal, which is a low risk area, I would take the view that you're going to be pretty safe as long as you obviously abide by the usual kind of sensible rules. But Kit Yates should come in here because he's a worrying Manchester City supporter, which, you know.
Yes, what do you think?
So yeah, I'm a Man City fan. I think I would have preferred to see it in the UK, although we would have been limited to 10,000 fans in the UK. If after the 17th of May, that's the suggestion of the number of fans would be allowed in UK stadiums. That's going to be the maximum capacity. At the moment, I think Portugal and UEFA have said that they're going to allow 6,000 tickets for each club. So that's 12,000 fans in total, which is obviously an improvement on what we would have had in the UK. And there's also, I gather the rules are you have to go to Portugal there and back in a day, and you're going to be kept in a bubble with the other fans, and you're not going to be allowed out into Porto. It's going to be held in Porto in the Stadio Dragão. And so you're not going to be allowed to venture into the city. You're going to stay in fan zones. So in terms of the risk, you know, you're going to be presumably mingling with other fans in the UK, but, you know, rates in the UK are relatively low at the moment. So the risk isn't going to be hugely increased in comparison to what it would be if it was hosted in the UK. Certainly it makes sense not to host it in Turkey, which has high rates of prevalence. They are still in the middle of a lockdown. And obviously it's on the red list, which would mean, you know, when you get back home that you'd have to quarantine in a managed isolation for 10 days. So it's certainly better that it's in Portugal than in Turkey. And if you do get to go to the game, I'll say, yeah, good luck, stay safe, be sensible, and yeah, come on City.
Thank you very much.
Thank you. Thank you very much, Ed. Thank you, Kit and Anthony, for those responses. And Independent Stage did put out a statement about the sense of holding it in Turkey. So perhaps Independent Sage has been half listened to here, which is somewhat reassuring. I'm now going to hand over to Professor Susan Mickey to introduce a new 6-point plan, which is, I think, is being published this afternoon, Susan.
Yes, I won't introduce it, but really just to say that it's there. And this really goes back to the discussion we had at the beginning of this session about the situation we're in with the new variants and what the implications of that as far as we collectively see it. So just to say, it will be on the website. It's only 2 slides long, so it's very succinct. But if I can just read out the headings of the 6 points, it will give everybody an idea of what we cover. So the first is the issue of global vaccination. The second is border controls. The third is improved local systems of outbreak control. The fourth is domestic vaccination. Fifthly, limiting indoor mixing. And sixthly, continuing vigilance. So we've touched on quite a few of those topics over the last hour, but I really would commend it to everybody to have a look at it. As I say, it's our collective view of where we are at the moment and how we should be approaching things.
Thank you very much, Susan. And with that, I'm going to almost wrap things up. All of the reports that Independent Sage has published over the months are available on the website, and that new 6-point plan will be up there this afternoon. So do go and find it there. And I would like, as is traditional, to invite Sir David King for his summary thoughts. Sir David.
Thank you very much, Alice. And I'll be quick. First of all, May 17th, a tipping point is what we've heard, because we're coming out of lockdown, a critical moment. And this is a moment as we come out of lockdown when I would have said, surely that's the point at which we must have a functioning find, test, trace, isolate and support system, because that is a much more well-judged system than having to go back into another lockdown. But we don't have that, and so we will simply have to keep an eye on how it goes. At the moment, we've heard the cases have flattened, hospitalization is down, vaccines are effective at cutting both transmission and deaths, so there's some very, very good news. But the question about the Indian variant, the B1617.2, and its the fact that it's now taking over as the dominant form of COVID-19 in the UK is a real worry, because although the statement was made that there is no firm evidence that vaccines don't deal with this new mutant, nor do we have firm evidence that they do. And so we are in a real quandary until we have some good data coming in to support that one way or the other. Let me just end with one major point. Supporting global vaccination is key to everybody's future. And when I say global vaccination, I mean in all of the countries of the world that currently can't afford or can't get hold of vaccines. And yet the Western countries are sitting on vaccines that at a much higher rate, and we could speed up vaccine production. Until we have this happening around the whole world, we are going to be subject to further mutations emerging, because basically these mutations emerge when there's a high density of virus around. So it's in our interest to see that we now look globally at vaccination rates around the whole world. Let's see what Britain can do. We've always kept a strong view on supporting developing countries. This is supporting ourselves as well as developing countries. Thank you.
Thank you very much, Sir David. Thank you, everybody, for watching today's session. Thank you to the press and the public for all of the questions. And thank you, Independent Sage, for your continued efforts. We're at a critical point in the pandemic, as Sir David said. Though we've all longed for the new freedoms that are being extended to us on Monday, we must proceed with caution. We've come so far, it would be foolish to throw away hard-won gains. The variants, as we've seen, pose a threat to our national safety that we can't ignore, and we'll be discussing that in much more detail next week with our special guest, Professor Ravi Gupta from the Gupta Lab in Cambridge, who's been investigating those variants of concern. So please do send us your questions on that topic for next week. Information is empowering. Independent Sage will continue to advise and share the science and look at the best ways in which we can all navigate through the pandemic to protect ourselves and each other. Please follow us on Twitter and Instagram as well, if you don't already. See you at the same time next week. Stay safe, keep well. Bye-bye.
Bye.
Bye, everybody. Thank you. Bye.